about balance, and it's all about trying to get something without paying too much of a penalty. It's not just a matter of choosing positive spherical aberration, it's a matter of choosing how much.
So Graham, can you tell us about the process that you went through to optimize EMV power calculations?
Rayner was able to collect 350 eyes, a data set, a clean data set from multiple surgeons. With that data set, you can calculate your optimized constant, which turned out to have a lens factor of 1.51, equivalent to an A constant of 118.3, which is significantly lower than was originally advised. If you do like a little bit of myopia, and the RayOne does enjoy a little bit of myopia, you better target it.
What are you actually targeting at the moment with bilateral surgery?
Traditionally for all my Presby correcting patients, I've used a lot of trifocals. And so eventually when I heard about the EMV lens that Graham had designed specifically for EMV, and there's a difference between using a monofocal lens and a lens that I think has been designed for monovision, I felt that I had to try it because I found some of the other EDOF lenses on the market have just been too variable in outcomes and just not predictable enough. So when I tried the EMV, it was like a revelation because there was so little downsides to using it. And I think this targeting is so important. So in the days of EDOF, I would target half a diopter for the reading eye.
And do you think you can hit that? Because, a lot of people say, I'll aim for minus a half, but we have a bit of variation in what we can achieve.
Yeah, but I think the good thing about the EDOFs and the EMV lenses is that they're quite forgiving. They have quite a wide landing platform, which is nice. I felt that if your lens already has 1.5 diopters inbuilt, I'd like to get it nearer to 0. So I target minus 0.75 for all my reading eyes, the other eye being maybe the first minus. And the patients I've done have really been very, very happy.
RayOne was designed to be a good lens to use with modest monovision. Modest monovision at minus 1.25 will give you great intermediate. It will give you a decent reading, but to be totally spectacle independent, you'll only get it in about 25% of cases. And so the extended depth of focus from the outset, I realized this was a great match with modest monovision. Personally, I think for EMV, if you really want spectacle independence, you need to target maybe -1.
Could I ask Graham a question? And one of the things that Rayner taught me when we started was to be careful of the amount of positive spherical aberration in the post-LASIK eyes. Is there an optimal positive SA or existing amount of positive SA that the lens works best?
For normal corneas, there's going to be a range of SA. The amount of positive that you add is small enough that I don't believe you need to check the SA of a normal eye. But if that's not the case, if it's a big correction, you think that zone is a bit decentered, it was done 15 years ago in a small optical zone, then you need to be cautious because the amount of pre-existing SA may be high enough that this lens wouldn't be a good partner. So my advice is to be cautious in post-LASIK. You are adding spherical aberration. In some eyes, it really would be worth checking before you do it or don't do it.
Yeah, I've heard you say before that the combination of positive spherical aberration and myopia is a nice combination. I'm no optics guru. Can you please explain that a little bit?
Sure. So the reality is, if you are myopic, you will impact the quality of your vision and your MTF will be reduced and your wavefront will be disturbed. If you have spherical aberration, you too will degrade that image. If you have both together, the same amount, both together, your MTF actually improves. They act synergistically. With negative, it's the opposite. If you're hyperopic and you have negative spherical aberration, they compensate for each other.
Kind of a useless combination.
Yeah, but that's one reason why preferring positive spherical aberration. you probably have better reading and intermediate with a neutral aspheric lens than you would with the classical negative SA minus 0.27, right?
Just remind me, how much positive is there in the EMV one?
It depends on the pupil, but you're probably adding about 0.14, 0.2, which is not very much.
Yeah,
Not very much.
it's amazing that little bit does as much as it does.
To me, quality of vision is still the priority, and I don't want to pay too much price, preferably none. And for many users of RayOne EMV, that's the experience, that they say, well, why don't I use for everything? Because the price you pay is often just not evident.
Yeah, I think we're still judged on quality of distance vision over range, to be honest. Ron, we've got lots of lenses out there. There are lots of lenses that will give depth of focus, monofocal plus, trifocals. There's so many now. How do you decide what lens you're going to use? Because you've got a lot of options available.
Sure, and let's talk about it in private practice. You know, the private practice patients are more demanding, but I would also say that in terms of developing your private practice, remember we had that talk yesterday, I would say Presby correction has probably been the biggest driver to success in cataract practice and by inference your private practice. So you need to know really what's out there, what's available, what works reliably and consistently.
Pupil size is an issue that comes up with all of these lenses, and the amount of positive spherical aberration you've got, I understand, is apodized, so it decreases towards the peripheries, like a trifocal decreases its ridges. And that idea, I understand, is so that even with a big pupil, you'll still retain depth of focus, but also quality of vision.
There will be an impact on your vision with pupil size. There's an impact on your vision with pupil size when you don't have a cataract, when you're phakic. The pupil is moving all the time and our vision is changing all the time, and there is no EDOF lens and no multifocal that's not impacted by the pupil. With positive spherical aberration, the amount of extension actually improves as the pupil gets larger, but the visual image will degrade more as well. So the optic design has exactly what you say. It has a tapering of the amount of spherical aberration just to try and maintain that quality in mesopic conditions. But the extended depth of focus is the opposite of, say, the negative spherical aberration, where the near response makes the pupils smaller, which would be an advantage. But if you're trying to read in a dimly lit condition, and that's when you're most challenged, the extension is gone because the pupils got larger.
What have your experiences been with a little bit of decentration with this lens? Theoretically, Graham, and practically, Ron, what do you think?
Well, I've noticed no issue at all. I mean, in fact, even with many of the other lenses, you know, we hear a lot about angle alpha, angle kappa, and I found that if you've chosen your patients properly, the impact isn't great, and I almost don't look at them these days. And I think that's what a lot of people will say privately.
This optic is very robust in the presence of decentration. Every lens has minor decentration. The fall off in quality or MTF with decentration with negative spherical aberration is quite significant. With positive spherical aberration, that doesn't occur. So it's much more robust in that context.
The other big question is pathology. And are you putting these lenses into eyes that have a little bit of macular disease or some optic neuropathy? Are you pushing the limits?
I am, and I've been pushing the limits with both trifocals. I mean, trifocals...
You've been pushing your limits your whole life.
Yeah. I've still been very conservative with trifocals. I mean, you know, it's such a demanding lens. You really need a pristine eye, and very rarely do I put it in any eye with any active disease, okay? And to a certain extent, maybe with EDOF, it's a little bit more forgiving. And so I think this was very interesting for the EMV. I mean, does it mean we can use it in patients with maybe some RPE degeneration of the fovea, treated diabetic eye disease? And if it's quiet, I think it's reasonable. And significant involvement of the macula. So I said, well, my first instinct, firstly, no trifocal, no EDOF, you should go monofocal. But then I thought, why don't we put an EMV in? okay? And I canvassed Graham. Graham felt maybe it wasn't a great idea, and I spoke to a few other people who all thought maybe it wasn't. And internally, I felt probably it would be okay, but if the patient didn't turn out well because of the fixation issues, the lens would be blamed. And I thought that was probably unfair I'm relatively new to the lens. So in fact, I've done her first eye, and I put in a monofocal, and I didn't put the EDOF. And she's only seeing 618 post-op because of the fixation. So I'm glad I did not put in the EMV. But I think on that, Graham, how far would you push the EMV lens in terms of macular or optic nerve pathology, being a monofocal essentially?
Well, you've got a much greater safety area compared to a trifocal, for sure. There has to be some point, though, where that extended depth of focus will impact in a compromised optical system. But how you find it, I don't know. But it's going to be much less so than with a trifocal.
I know how we find it. We leave it to him. You can push those mountains.
When delivering the IOL into the eye, personally, I just take it slowly. And if I see the haptic coming out, I'll rotate my injector. And it hasn't caused any problems. But what do you think, Ron?
Rayner had told me that you probably should go through a 2.4 incision rather than my standard 2.2. But pushing limits, I like to stick with my 2.2. So one of the very first cases I did a 2.2, wound-assisted, injected the lens in, and it comes out upside down. Okay? In other words, it comes out in the S instead of the Z configuration. And I mean, it's not nice to have that, but on the other hand, it was a very easy lens to just flip over. And Graham, I'm going to ask you this. So does it matter if the lens goes in upside down, and can you leave it there if it's upside down?
Optically, it shouldn't matter that much because it's not vaulted.
But it's a planar lens, right?
The power, the aberration is on one surface. I would always tend to flip it if I saw it.
It's easy to flip.
It's easy to do.
Now, the other question that sort of commonly comes up with Rayner lenses is hydrophilic versus hydrophobic. Now, I think I've spoken ad nauseum about this, that I think it's a tiny risk of a risk, and it's a risk that I'm happy to take for my patients, but ultimately it's their eye, so it's a consent issue, and I discuss it with them. What are your thoughts?
To me, if the optical properties of the lens and delivers what I want for my patients, so what if it's hydrophilic, as long as they don't opacify? And I think there's no evidence that this particular lens opacifies over the years.
When you were designing the lens, did you think about whether this should be hydrophobic or hydrophilic?
It's always a compromise, Ben, because when a lens is in the eye, nothing looks better than a hydrophilic. Nothing. Optically, it's just a perfect material. We've been through history of episodes of calcification with hydrophilics, and I think even though Rayner will say that the chance is extremely low in their data, I mean, 1 in, I won't give a number, extremely, extremely low. If you've got a patient who's got a compromised cornea, which you think may need a DSEC, or that you are considering doing an epiretinal membrane, in those particular contexts, I would not use a hydrophilic.
Common sense.
I would not.
Thank you very much.
Thanks for the questions, Ben.
My pleasure.